Welcome back to my channel. I'm Coach DJ. I've got Kurt Havens with me here today.
What's up?
Today we are going to talk about something not quite as exciting as, anabolic design and structure, but just equally, if not more important, some of the lifestyle changes, habits, and maybe nutrition and supplements that people can utilize, maybe when using TRT or in a prep to kind of help preserve certain health markers during this time period.
Cool.
So where do we want to kick off with this?
Do you want to focus more on women or on men or on both? A lot of them,
I
there's
think
overlap between the two.
I think both. And realistically, and I'm sure you see a lot of this too, especially in terms of just standard TRT, we see people that say, hey, I want to get healthy. I want to lose a little bit of weight. And they kind of do things backwards instead of getting more active and prioritizing protein and watching what they eat. They start testosterone and kind of see how far they can ride that out. And then when they hit a perceived plateau or they're not getting the results they expected, then they start looking into what can they change in terms of training and nutrition.
True. Yeah. I mean, it makes sense. It is the opposite of what should occur, though, right? I mean, both you and I probably started in a place of health and fitness first, and then you would look at hormones later when they start to decline, not as the primary way to remedy being out of shape.
I think one of the things that a lot of people tend to overlook is we talk about foundation work all the time. And even when we're talking about creating cycles or getting into polypharmacy, we always talk about a foundation. But there's a big role in foundation before the anabolics, before TRT, even before leveraging testosterone. You simply have to make sure you do have your training in place. And if the goal is to lose body fat, rather than depending on pharmaceutical compounds or artificially inflating your BMR, then we have to see what we're eating, aim for a calorie deficit. And if you want to grow, so many people do not eat enough food to have that ability. They're
Yep.
drastically under eating. And again, they kind of skip all of those foundation steps and then they turn to hopefully increasing testosterone with hopes that that will take care of what they didn't have set up before. So I think that the biggest thing is kind of setting up a good foundation in terms of hormones. A lot of people don't check their hormones before starting exogenous hormones either. We don't really know what we're trying to correct, what the baseline looks like, what approach you should take. They just immediately implement testosterone. They're not in a specific deficit or surplus. None of that is put together.
Okay. So that's interesting. So I guess that would be the approach of someone going to do this through an underground lab on their own, right? Outside of a physician.
I think I see it in both situations,
Okay.
honestly. Like I've seen people that will get their lab work, get a TRT prescription, and make no other lifestyle changes
Okay.
at all. Or somebody that just says, like, hey, I don't like my body. I don't like how I feel. I must have low testosterone. It's
Hmm.
not that I live off gas station hot dogs. It's not that I get 4 hours of sleep a night. I must have low testosterone. My buddy gets this. I'm going to start taking it.
Of course, right? And they assume that at the actual TRT level that it's some groundbreaking thing, that it's going to,
Yes.
completely transform their entire life. I think that there's a huge value in TRT. I think from a physical output stance, though, it's not going to change the way you look immediately. It's more of a long-term thing, right? It would be like using growth hormone over time. It's not a dramatic, immediate change. The only people that I know of, like a group of people that see a relatively fast change from TRT level testosterone, are people that are obese. Assuming that they're not huge aromatizers or you manage your estrogen, they seem to lose body fat very well on low amounts of testosterone versus like your average middle-aged guy. It'll improve, right, his cognition, his sexual function, and a lot of other metrics, but it's not going to, I don't think it's going to change their physical aspect without them changing diet, exercise, just general lifestyle stuff like you said. I think
So when you get, let's say you have a new client, they are on TRT. And when we say TRT, I would like to point out we are meaning like testosterone replacement therapy. We're not talking about grams of gear and additional anabolics. We are just on testosterone, maybe anywhere from 120 to maybe 250 milligrams
Mhm.
a week. You get this client in terms of structuring nutrition. to support health, because that's always going to be
Mm-hmm.
prioritized. Whether you are a bodybuilder or you're just trying to make better changes, health is going to be prioritized. What type of things do you personally make sure you are implementing with their nutrition, or the changes that you have to make based on their prior nutrition?
So with the uh, calorie wise, we're looking at weight loss
Yeah,
or
we can
either.
use weight loss.
Okay. So I would say for weight loss, typically, you know, the rough math is to lose a pound a week, you need to be in a 500 calorie a day deficit. But it could be less than that, depending on the goal, right? You could be in a slight deficit, a 200 calorie, 300 calorie deficit a day. And the same with trying to grow muscle. We do the opposite as that. I don't think people eat enough to grow muscle, but I don't think they need to eat this like huge abundance of food either, right? Like you're not trying to mimic what the local, pro football player eats. Um, I think the things that I would look at first are protein consumption. So the silly recommendation from the RDA on protein is way too low. That's just to prevent disease. And it's been shown time and time again in different populations, actually, especially in women, when you increase the protein to an adequate amount, they actually lose body fat and gain muscle, even when calories are equated and exercise is non-existent. So protein would be the first one I would look at after, basic calories. Fiber is hugely important. And I think, in the right place, it doesn't need to be this massive amount either, but it needs to be there and present. I think essential fatty acids, which you generally would have to supplement from. I don't think most people are eating either enough grass-fed and finished meat or enough wild-caught fish in a week that they can go without it. And then I think that becomes adequate energy then to support the goals, whether it's fat loss or not. And generally for someone who's athletic, assuming that they're not diabetic or have some other metabolic reason why they can't eat carbohydrates, I would fill most of the calorie requirements in with carbohydrates, and then I would use dietary fat to support things like getting those essential fatty acids in.
And typically, when we look at our best sources for omega fatty acids, especially with the types of nutrition plans that you would be utilizing with our clients, we're really not getting great sources. So it almost always has to be supplemented. I think you and I probably spend a lot of time discussing omegas, specifically omega intake, and the importance of it and the roles it can have. But most people are going to benefit greatly from that. And when we look at some of the potential risks and issues that people may experience with elevated androgen use, omegas can be one of those really
Mhm.
important things that we incorporate. I think people really tend to overlook how big of a role diet plays in some of those side effects that they may see with the use of testosterone.
Absolutely. Well,
So,
I mean, a tree or a plant grows better in healthy soil than it does in depleted soil. It's the same as our body, right? It's going to lose fat better or grow muscle better if you get all the nutrients that the human body needs in order to survive.
and in terms of body composition too, I used to think that this was an issue that I would see primarily with the female demographic, but now I see that it's an issue across the board, is lack of protein. And how many people want to start anabolics because they feel like they've plateaued, they're not recovering well, they can't grow any muscle. But then I have males, average size males, that are eating 120 to 150 grams of protein a day, mostly through shakes. And then females telling me that they eat really high protein, but they're eating 100 grams. And I don't think necessarily, when we look at the recommended dietary intake for certain foods and macronutrients, it's really not going to be the same thing as what we're utilizing to capitalize on, not only with the use of exogenous hormones, but just for muscle retention and development in general. Because what we're trying to strive for is technically unnatural. We're trying to be lean
Yeah,
and muscular. Those things
yeah.
don't go together.
Not what nature wants at all.
And then when we're dieting, we're constantly putting our body under more stress. So that's, we're continuing to strength train. So what we're doing in general is unnatural. And I don't think people understand that they might have to make dietary adjustments to get the results they're striving for, even if it doesn't necessarily coincide with what we're conventionally doing in terms of health and wellness.
Mhm.
So with testosterone, the biggest issues and concerns we tend to have, we'll see people that might have blood pressure management issues, generally predisposed, um, issues with blood viscosity, increased EPO production. What else do we see with
Cholesterol,
estrogen conversion?
estrogen conversion, and cholesterol.
cholesterol. So what
Blood
do you
glucose
do in
sometimes,
terms
but
of,
not direct.
we start with, in terms of like blood pressure, blood viscosity, what are some things that you typically implement?
Well, it is the blood viscosity actually changing from the HRT, the TRT, or is it the labs are performed incorrectly, right? So when
I almost always see it's usually poor hydration. And if
yeah,
it's,
that's what
I
I
don't
was
know how
going
you
to say.
feel about it. If we see slightly elevated RBC, it's independent. We don't see any other elevations. I don't treat that any differently than
No,
somebody that lives at high altitude. I don't pay attention to that.
I think the misconception when doctors tell patients or nurses tell patients to be fasted for blood work, that doesn't mean you need to be dehydrated. It's the reason, again, this might not be a popular answer, but the reason why we're taught to tell patients to be fasted for blood work is because what they eat before their blood work will affect their blood work, notably uh, like things like cholesterol. So if you were to eat a bacon, egg, and cheese from Dunkin' Donuts and go get your blood drawn, your cholesterol will immediately be skewed. Versus if you just ate a low-fat yogurt, it's most likely not going to affect anything. Your
Mm-hmm.
blood sugar will be shifted from these things. But again, if it's noted that you're not fasted, it's not a big deal. Um, that being said, if you're going in fasted doesn't mean you shouldn't go in hydrated. I think you should definitely go in hydrated because that will skew your blood viscosity, right? If you've now gone 8 hours of sleep, assuming you actually get 8 hours of sleep, and then you go in, now you've not drank water in 9 or 10 hours, your blood is going to be much thicker. It's
And
one of the,
typically, I find if somebody's not eating in the morning and intentionally, and you just say the word fasted, a lot of people just don't know that they can drink water. It can be a matter of just forgetting because you're not pairing it with food, and not everybody's chugging water all day like we are. Um, or they think fasted means absolutely nothing for
yeah.
blood work
Well,
purposes. So
because
they are following instructions, but then when we get that blood work back, it's not always
yeah,
entirely accurate. And then I see a lot of people that are unnecessarily engaging in therapeutic phlebotomy on a very frequent
correct.
basis.
Yeah, and you're losing some of the performance benefits of increased hormones by doing that, and it's
And this
unnecessary.
is another one. If blood viscosity is truly an issue for someone, I find that it's probably going to be, it'll normally be problematic prior to the introduction or increase in other androgens as well. But omega fatty acids, vitamin E,
Mm-hmm.
even small things like turmeric, there's other things that you can utilize because there's so much. And again, blood work can look scary when you get those labs back, especially if maybe you are doing this independently. You maybe don't have physician oversight, but you are trying to do this responsibly and you're pulling labs and then they come back and there's red numbers on there. It's terrifying, especially if you don't have someone guiding you through that process or maybe explaining it and asking the follow-up questions of, hey, did you drink water before you went in or did you go to bed at 8 p.m.? And this is how we're pulling the labs. But a lot of these things, there are over the counter solutions that can help with
Yep.
this that so many people overlook. And again, we've kind of created a culture, especially within the bodybuilding realm, where we've accepted people are using performance enhancing drugs. Now we come up with mitigation tactics. And this is where we kind of see the overprescription and overuse of ARBs for
Yep.
people that probably
Don't need
don't
them.
actually
No.
need them. There's no hypertension issues. And then they're trying to use it as a way to handle blood viscosity. They're taking ARBs at 22 years old when they could have just taken omegas
Yeah.
and drank water before their labs.
Or they're using ARBs for elevated blood pressure that's due to other things and not blood pressure innately. So, if you're not prone to that, if that was not the cause before, or wasn't the case beforehand, most likely it's not the cause from testosterone. It would be estrogen or other things like that that should be looked at, not just right. Like telmisartan should not be used prophylactically by a 20-year-old man on TRT. First of all, I don't know. I'm not quite sure why there are so many 20-year-olds on TRT to begin with, but it shouldn't be used. Drugs like that, that's not the root cause of these issues, right? But doctors, the trend in the market is to stay away from the estrogen issue, and they want to do everything else they can outside of that.
Now, in terms of estrogen, because that is a really big one, and I know you talk about estrogen frequently, and I'd say 99% of the questions we get are regarding estrogen. I have found a lot of people, especially when beginning TRT, might struggle with a slight increase in E2. And obviously we have an increased rate of aromatization. That's to be expected. But a lot of times I see an elevation that there's other things that can help control that. We don't always necessarily have to jump straight to an aromatase inhibitor. I still see physicians prescribing injections once every 2 weeks.
Yeah. Yeah. So a frequency of injection, the size of the injection, right? If you were someone who's a heavy aromatizer, I would typically have them inject more frequently, the smaller doses, split the total weekly dose up into daily. You can always use an insulin needle and do it that way. That generally will prevent a lot of the DHT and estrogen issues that are associated with bigger doses. Yeah, there is no ester that I'm aware of that should be used every other week. That's not an appropriate use of testosterone, right? Even a decaconate is not an appropriate thing. I wouldn't use that. Even with a half-life of 14 days, supposedly, I wouldn't be using that every 2 weeks. So with cypionate is the standard ester prescribed in the United States. That has an estimated half-life of somewhere between 6 and 8 days. It should be injected twice a week, at minimum.
When we talk about injection frequency as well, obviously this is not going to apply to those that are using this strictly for performance enhancement and on large quantities. There's going to be some limitations in terms of what you can do, especially with subcutaneous injections as well. And there seems to be a lot of, if you actually even just take it to Google or a Reddit forum or like these places where a lot of people are getting information, as a rule of thumb, if I have someone that maybe isn't an ideal body composition, we are aromatizing, but it's not to the degree where I would necessarily want to jump straight to an AI. I'd like to change administration and see if we have an
Mm-hmm.
improvement. I will go to more frequent subcutaneous injections, but a lot of people have been told to avoid that because they've been told that there's more aromatase enzyme activity in adipose tissue. So if you inject adipose tissue, you will aromatize quicker, but that's not the
It's
case.
not
It's
correct.
metabolized differently. It's actually more ideal to do more
It's slowly
frequent
releasing.
subcutaneous injections.
Yeah,
Now, obviously, if you're on a lot, you can't, but
yeah, it's the same. It's the same theory. It gets confusing, and doctors get confused with this stuff too. It's the same theory as injecting sub-Q versus IM for anything. It doesn't necessarily interact with the immediate area that the injection goes into. That depot still needs to. There's still the ester. What is slowing the release still needs to be cleaved off by esterases, which is the enzyme that's going to cleave that off and release into the bloodstream. So it becomes systemic regardless. It's not interacting with the immediate area. Like it's not interacting with adipose tissue just because you put it sub Q. It's not interacting with your gluteal muscle because that's where you injected it. Otherwise, like I would have an enormous butt from, tens of thousands of milligrams of testosterone placed there.
if
That's not
that
the way
were
that
the case, I
works.
would be injecting my glutes every day. So
Exactly. And unfortunately, it doesn't work that way. You can't spot inject, right? There is some level of inflammation that occurs in a spot injection, but that's not, inflammation is not muscle growth. So that's kind of we could do a whole video just on spot injections. Um, yeah, I would definitely use those protocols first. But again, depending on where estrogen is, there's nothing wrong with using an AI, right? For some reason in the market now, everyone is against using an AI when this is a drug these are a class of drugs that this is what they're designed for. And
they're
for,
fearful of it. I mean, it's
yeah.
really ingrained that
And
AIs
honestly,
are
I would be
terrible.
more fearful of having super high estrogen as a man than I would be of using an AI. You want your estrogen in range. We're not talking about pro bodybuilder level where your androgen load is really high in the thousands of nanograms versus, and then you can have a slightly elevated estrogen level. At that point, I still would keep it, you know, I wouldn't let it go too high. But for someone on TRT, if your average testosterone level is 900 or 1,000 nanograms per deciliter, you don't really need an estradiol of over 40. I don't understand why you would ever let it go higher than that. It's going to make losing body fat much more difficult. It's going to cause weird body fat storage issues. It's going to emotional issues. It makes no sense to me to let estrogen ride so high. It's going to slow your thyroid down.
And it is a pop. I mean, I got several comments yesterday. I made a video on estrogen management, and somebody had immediately commented that you're not supposed to treat it unless you get gyno. Like unless it starts causing noticeable issues, you should not treat it. And they presented that as like a hard fact. And then someone else had mentioned that they were scared of AIs because their doctors had basically put them off from it from their prescribing clinic and that they shouldn't ever be taken. And then someone said, well, estrogen is anabolic. So
It is.
unless I'm getting gyno, why should I not let my estrogen get as high as possible? And unfortunately, I think we hear people hear select bits and pieces, and then the interpretation gets really skewed. And this is why we end up with men that are now intentionally trying to increase their estrogen.
Yeah. So estrogen is not anabolic on its own in the classic sense, right? It's not building muscle tissue. It contributes to bone anabolism and some other tissues, but not muscle directly. It is not anabolic in men. It is not anabolic in women. It's not what causes muscle growth in you. That would be progesterone, right? This is why nandrolone is a naturally occurring hormone in a very small amount in pregnant women, because that's what's allowing the fetus to grow. It's not some elevated level of estrogen that's causing the baby to grow. It's letting, beside the reasons that I just mentioned about elevated estrogen, it's not doing anything positive. It does protect your organs to an extent, but that is within range. That is not some elevated level that's doing this. Where this came from, some doctors started playing with letting estrogen rise higher a few years ago, and then it became this absurd thing. And then you had social influencers that were basically talking about some advanced way to leverage testosterone, where they would use testosterone as a base for a stack of things and keep the dose lower, because at that point all testosterone's doing is providing estrogen when there's other anabolics in the case,
Mhm.
in the stack, and then letting the other anabolics drive anabolism. And they were saying, don't squash the estrogen, which makes sense. If you're just using testosterone for estrogen, why would you crush the estrogen? But in someone who is on TRT, that's a totally different scenario than someone that's using performance enhancing drugs and understands how to leverage different things. It's the estrogen needs to be managed in an appropriate way. That doesn't mean all the time they need to be on an AI. It doesn't mean that an AI is always used. It just means keep your estrogen appropriately ranged, right?
And do what you
There is
need
a
to
reason why
do
it's
to achieve that. Like, I'm a
right.
huge fan of what can we do in terms of lifestyle changes and nutrition to manage
Yeah.
certain
And
things.
if
Like,
you
I'm
can't
a
manage it through
huge
that,
proponent.
then you find other ways to manage it. There is nothing. This is kind of like something that you and I look at all the time. I'm not aware of any hard studies that show that drugs like Arimidex cause any actual harm. So
And
I'm
if
not
you
sure
need
where these
it,
doctors are
you
citing
need
this
it.
stuff from. Yeah,
One of
if
the
you need
things
it,
that
you
I'm
need it.
seeing now is men that are struggling with estrogen, and I don't mean like maybe we're 50 with a total test of, I don't know, 800 or something, but slightly struggling. They're being told to just eat more cruciferous vegetables. And I think it's also important to realize that as much as we advocate for trying to handle things, from a foundation perspective, if you need if you need pharmaceutical interference, you do. There's nothing that's going to change that. And eating a ton of cruciferous vegetables in theory to increase DIM intake is really not going to be the same thing as taking an AI. Those are
No,
not interchangeable
no.
at
And
all.
Dim
And I see a lot of people just trying to shove a lot of broccoli into their day,
and Dim has
trying thinking it's
interactions.
going to have a drastic impact.
Dim has interactions with the androgen receptor as well too. So increasing Dim for a man is not necessarily
And
this
it can be
advantageous type thing
negative.
either. Yeah, and so it's and nothing wrong with. I'm not against eating things like broccoli, but increasing trying to increase it that way, and also saying you're against using pharmaceutical drugs like Arimidex, but yet you're on a pharmaceutical drug like testosterone, it doesn't make any sense, right? Use the appropriate drugs for the appropriate situation, right? They're just tools in a toolbox. They're not always needed, but sometimes they are needed, and in that case, it would be appropriate to use.
And now, in terms of lipids, I don't know if you can, I don't know if the audio is picking up on my very, I don't know, shutters. But in terms of lipid management, I would say 99% is going to come from diet. What do you, if you get someone and maybe we have reduced HDL for whatever
Mhm.
reason, we have elevations in LDL, cholesterol may or may not be within range, same with triglycerides. What are some approaches that you automatically implement when you see that on lab work, with or without testosterone in use?
Okay. So generally, well, without testosterone, um, kind of a sweeping overview is HDL a lot of times is affected by hormones. Estrogen specifically will affect HDL in men and women. That's one of the reasons why you don't see heart issues in women until they're postmenopausal. It's because they have an elevated level of estrogen. Now, again, I'm not flipping back on my story. There is an amount of estrogen that's needed for health. That doesn't mean that it's out of range. So a lot of times HDL will drop then on testosterone because of the DHT component. So androgens interact, that is a non-genomic or an androgenic effect of testosterone, is that it interacts with the liver and its production of cholesterol. And DHT does that specifically. Testosterone, one of the things it turns to is DHT. So that's a great place to make sure that estrogen is in the right range for HDL. LDL tends to be more lifestyle related things: lack of fiber, lack of exercise, too much refined garbage, too much saturated fat. But again, cholesterol in and of itself is more important as an overall, like ApoB or ratio, and triglycerides, not just as any one of the markers, right? Like a cardiologist will say that all the cholesterol markers are independent risk factors for heart disease, but yet that's not incorrect, but it's not necessarily correct. Just having low HDL on its own is not necessarily going to cause heart
Mhm.
disease. It's a contributing factor to a bigger picture. But lifestyle changes like increase your cardio, eat more fiber, um, things like that will, making sure estrogen within the range should fix most of the cholesterol issues. What about you? Anything else that you do immediately?
The two main ones that you said so casually are so overlooked. I can't tell you how many people are against adding cardio or just won't. It's usually one of two things. It's I have a set amount of time in the gym, I want to capitalize on it for gains, and they only want to lift, or and so they're just not doing the cardio, or they're terrified that it will impact them negatively. But I'm like, well, man, you're like 30% body fat. Like, you doing some cardio isn't going to hurt anything. It's not going to negatively impact your muscle development or retention to throw in a little bit of steady state
Yeah.
cardio post lift or separately. And I think a lot of people, it's not always fun to make certain dietary changes. I like to implement plant-based fats. I always want omegas. Sometimes I'll use berberine. I like berberine a lot. But daily movement. So many people are seeing reduced step count. Even you and I working from
Yep.
home,
Just
like
walk.
you just got to move. Cardiovascular health is really underrated, especially in terms of managing health markers and lab work. And that's probably where I argue with a lot of my own clients is like, if you're not getting in at least enough cardio or energy expenditure per day to where I think we're going to be able to approach another phase safely, like we're just going to skip it. If you can't prioritize getting in basic cardio for health purposes, I'm not asking you to run a marathon. I'm not asking you to do an hour of Stairmaster a day, but just enough to help keep these markers in place. And it is a drastic improvement
Mhm.
when we see that. And again, the sources of dietary fats tend to be a big one. I don't think most people particularly enjoy the plant-based fats that I have people add in. I've never gone for a snack and been like, man, I could sure go for some avocado and almonds. Like that's
Macadamia nuts.
never at the top of my list. But those little steps are things that can
Yep.
potentially keep you off statins long term, and they do have an impact. And it's quick too. Bringing up HDL is definitely going to be a longer journey than just like reducing your LDL, but the lifestyle factors are huge in that. And even with added supplements, aren't taking if you aren't paying attention to your sources of fats and you're not moving, you'll always have an issue with that.
Yeah.
So that's in terms of supplements, that's really all that I utilize specifically. I've never had to implement anything outside of that. Even people that, might have certain predispositions and that's something that they've struggled with alone, just even just omegas and movement can
Yeah.
be.
Yeah. Usually it'll fix most things.
And then when we start kind of we're going outside of just testosterone use and maybe we're looking at a competitor or somebody that's just really taking all the anavar that's available from all these clinics,
Mhm.
and we start looking at maybe some of the other risks associated and certain stressors that we see from injectables and orals. What are some of the standard approaches that you kind of look at, or do you have any kind of blanket approaches or supplements that you do implement?
Um, well, I think the things to then start to look at would be kidney health, liver health. Obviously, cholesterol will be impacted. DHTs and orals especially will impact lipids greatly. Certain 19 Nors will do that as well. The I mean, I would use things. Well, things like orals should always be minimized. I know in the female population there aren't as many options of injectable things that are used, and I know that women tend to want to jump on things like Anavar initially. Um, in men, at least, I would orals should only be used as a last case before a show. They shouldn't be used um, sporadically throughout the year. That's something that I'm against. There's very little that they do that's something that's injectable won't do better in most cases. And it's important to look at these things, right? Because when kidneys start to go, they go, and there's not a lot of warning signs when they
Mhm.
fail, right? Where liver, you can generally see in someone's appearance the way they feel when the liver starts to go. You have to really abuse your liver to make it go, but it can go over time. Things like Anadrol in men, really liver toxic. Superdrol, Winstrol, halo testing can be, but most people don't abuse halo testing for long enough or in high enough doses that really is going to cause a problem. Anavar would be more kidney strain, but it's rare. I've seen it where it just, EGFR kind of lowers from Anavar use continuously a little. If guys are using 100 milligrams of it for 6 or 8 weeks, it will definitely put stress on your kidneys. Blanket statements, I feel like in that situation when someone's using lots of performance enhancing drugs, it totally depends on the individual. I mean, again, that's when food becomes more important, cardio becomes more important, supplementation becomes more important. All of these things are much more important in someone who's really using all those different drugs versus someone who's just on TRT. I think TRT patients need to have a foundation of health first and implement that daily. I think that someone who's actually abusing drugs needs to be really careful with what they do, right? It's about not drinking alcohol, not smoking, all of those things. Those are what's really going to kill somebody who's using steroids.
And it's crazy how many people will still continue to utilize, you know, maybe recreational drugs and alcohol while also trying to leverage performance enhancing drugs and multiple compounds at that. I think that, and that kind of what this all always circles back to, no matter what the conversation is or topic, is going to go back to lab work and kind of having a background information on compounds. I know there's suddenly been an interest in certain aspects of pharmacokinetics and pharmacology because everybody's like, oh, well, now I'm a chemist because I like steroids, and we're seeing a rise in popularity. But unfortunately, when you only have a very elementary understanding and you're kind of lacking that foundation, that's not always enough to maybe execute some of these cycles in a safe manner. And that's where it becomes very important to understand the risks of certain compounds. What some compounds that people take can actually deplete your body of specific nutrients that might require supplementation while you're on
Yep.
cycle. Like there's you have to you it is very important. And some people might look at my information or yours and be like, well, that's nerdy stuff. Like that's too much science. You don't need that much. Like nobody needs to know X, Y, and Z just to run, test and master on. But realistically, to be safe about it and get the most out of it, you need to understand the potential effects of the compounds, potential drug interactions. And going back to pulling labs, you might not know if you have certain predispositions already. Maybe you haven't exposed yourself to something that would trigger something that'll impact your health markers. And a lot of people are hesitant to pull labs on cycle. They'll maybe do it before to make sure they're in a good starting point, and then maybe 8 to 12 weeks after they've completed, which is a great starting point. But I encourage people to pull lab work while on cycle. How do you know where your estrogen is?
You wouldn't.
We've had this discussion before. Can most people identify it? Not always.
No. I
No.
mean, there are feelings associated with high and low, right? But I mean, that's not a great barometer. It's not accurate.
And you're not going to know what needs correcting if you're not able to pull blood work during that time frame. So it kind of always circles back to that. And if you start to see increases in certain markers or reductions in others, that kind of gives you a plan of action. So yes, we can go in knowing what risks are there, maybe add in certain supplements to help mitigate those when applicable. But at the end of the day, you're not going to know
No.
unless you pull lab work.
The only other one outside lab work that men especially should be checking their blood pressure if they're using lots of androgens. Not necessarily, I mean, it's a good idea to know what your blood pressure is regardless, but I don't think that most men on TRT need to be checking regularly. But once men have implemented other, especially androgenic steroids, checking blood pressure is very important. There's a couple different things there that'll skew that.
Okay, so that brings us to thyroid, which we've been discussing a lot this week. You put up a really good post, and thyroid, I think the biggest thing that I always try and reiterate to clients, especially if they've come to me after already being in a diet phase for a prolonged period of time, is your body is going to have natural down regulations occur when you are in a deficit for a prolonged period of time. That's what your body is supposed to do. That is,
Yep.
it's doing its job. So sometimes we can pull thyroid labs, and maybe certain things are not ideal. And this kind of circles back to, again, working with someone or a professional or a physician that actually specializes in this and knows how to interpret lab work. And this kind of circles back to estrogen to some degree, which is something
Mhm.
you posted on about earlier this week on your Instagram in a discussion we had. Do you want to kind of touch on
Yeah.
that?
Well, with that, so like you were saying, I think it's very important if you have issues with your lab work that you work with the appropriate doctor on these things. So diagnosing a thyroid issue is the job of an endocrinologist. It is not the job of a general practitioner. It's not the job of a podiatrist. It's not the job of a cardiologist. Everyone has their own specialty. Thyroid is very complicated, and there's a lot of things that interplay and affect the way the thyroid works. What I'm seeing specifically now is estrogen being out of range and it's slowing thyroid down. And it usually shows in TSH on lab work. And because of this adversity to using an AI, a lot of the clinics are letting estrogen get really elevated and it's slowing the thyroid down. And whether it's done intentionally or not, they're using it to open the door to sell thyroid medicine to patients who don't need thyroid medicine. And that's a really dangerous road to creep down. If someone actually has hypothyroidism, then medicine is needed. But for the large percentage of the population, it is not needed. Thyroid disease is not that common. And in men, it's very rare because it's actually directly related to estrogen levels. So this is another reason why you don't want to just let your estrogen creep up crazy high, because it will slow your thyroid down. And it's directly responsible for a lot of these things, including thyroid cancer. So I would be very weary when one of these telemed or online clinics is trying to prescribe a man thyroid medicine. Generally not what's needed.
And I think there's a lot of confusion as well, especially because of the overprescription that we're seeing. There's a difference between less than optimal on anything, not just thyroid, versus an actual hormonal imbalance or something like actual hypothyroidism. There's going to be a difference, and especially I've actually had clients come to me where they've worked with a telemed practice, and they were told, they were terrified. They were told they had Hashimoto's.
Yeah. So Hashimoto's,
They never pulled any antibody markers. Like there
yeah,
was
which
none of the labs were pulled.
of course. And so Hashimoto's is not that common, especially in men. I have seen it in men, but it's very obvious. Like you said, you can see it in those immune markers. And in things like TSH, the numbers are usually ridiculous. They're in the 50s. They're very, very high. It's not mistakable. It's not like I have a TSH of 3 or 4 and I have
Mm-hmm.
Hashimoto's. It's not like I have a little bit extra fat around my waist and I have Hashimoto's. It is an actual medical issue that's not common. And it's relatively easy to diagnose if the right tests are run. But these clinics are not doing the right tests because they're not aware of how to test for these things. Right? And at the end of the day, they're trying to sell supplements or medication. They're not that concerned with what the right diagnosis is.
And even when we see the medications being prescribed, they're not having conversations
No.
about, thyroid metabolism and, goitrogenic foods and when to
Yeah.
pair and when to avoid. We're not seeing that part of the discussion with these prescriptions. Unfortunately, sometimes they're not even designated to be taken in fasted states or something.
Yep.
That those conversations are frequently not had when you are being prescribed them in this specific scenario. And I think a lot of people, again, they don't necessarily understand how much you can improve thyroid through lifestyle
Yeah.
choices,
Iodine,
selenium and
selenium.
zinc
Yeah,
supplementation,
exactly.
things like that. And they jump straight because, again, there's a big difference between dysfunction and an imbalance versus not optimal.
Yeah, 83% of Americans are deficient in iodine. So that could be part of the issue right there. People have slower, than ideal thyroids.
And again, this is where, starting to play with hormones and compounds without a foundation or baseline understanding of even thyroid function. There's a lot of people that don't really understand even the relation of
Yeah,
TSH to thyroid, or where it's coming from, what it's signaling. So without that basic information, and then you just blindly accepting medications that are being offered you because you're not in optimal ranges, again, diet, lifestyle, huge factors. So many people are going to think that they have sluggish, terrible thyroid function. And I'm like, well, you've been in a deficit for a year. You've been on like a crazy
metabolic
weight loss
adoption.
journey. Let's bump up food and we'll take care of that.
Yeah. Yeah. It's called metabolic adoption. It happens at any diet. It will always hit a wall, and your body will compensate by slowing things down. That doesn't mean you've done damage. It's generally reversible. It's just you need a diet break. Like you said, it's not jump on thyroid medicine. It's not use time to use T3.
Yeah, metabolic adaptations can be both positive and
Yeah.
negative. I wouldn't have been able to consume what I eat right now 10 years ago. Absolutely,
Yeah.
absolutely not. But I think the biggest thing is not everything needs a pharmaceutical approach
No.
right away. But then in saying that, it will be grossly misinterpreted that you should never use a pharmaceutical compound. AIs are terrible, and that you should only handle things naturally.
Yeah. Or circumnavigate them with the wrong drugs, right? Like you're not going to fix an estrogen issue with the side effects from an estrogen issue by using telmisartan, other ARBs or other these numerous other drugs just to rather than use the proper drug like thyroid medicine rather than actually address the issue.
And sometimes addressing the issue is not fun. Sometimes it can be a journey, and it can be expensive if you're paying out of pocket for labs. It's just part of it though. But again, like you will have more longevity in your health and your fitness journey as a competitor in any capacity if you are working from the ground up and you have all that foundation in place and you are making the lifestyle changes. It is not fun. I know we love to talk about compounds, but at the end of the day, it's really going to come down to nutrition, training,
Yep.
cardiovascular health, and keeping certain baseline hormones balanced and within ranges to optimize everything
Yep.
else.
Yep. Absolutely. Yeah. All the drugs in the world are not going to fix poor lifestyle habits.
Is there anything else you want to add today? We'll go ahead and keep this one pretty short.
I just think that people, if they have questions about their labs, you seek the appropriate medical care. Don't just rely on what an online clinic is telling you to do, based on their business model, the way they structure themselves, what products they're trying to push. It's okay to ask questions. If they can't answer your questions appropriately about these things, then seek someone who can.
And Kurt, you offer consultation
I do.
calls as
I do
well.
as well. Yep. Same as you.
Okay.
Yep.
And real quick, you have a new course out. Can you kind of tell us a little bit about that? And I'll
Uh,
put the
yeah,
information in the description.
Big Paul and I did some learning modules online. So it's more geared at the moment toward the anabolic end of things. So we're doing like the pharmacology of these drugs and the way steroid cycles are structured, why the different drugs work, how to combine them, when to use different drugs, when not to use certain drugs, and just the reasoning behind all the craziness that bodybuilders do. And it's available. They're all videos. There's 83 videos, I believe, at the moment. We will continue to add more. There will be well over 100 shortly. It's available on anabolicbodybuilding.com. We can put a link below.
We'll do that.
Cool. Thank you so much.
Okay. Thank you so much for joining
Yeah,
me today.
definitely.
I'll see you next time.
Take care, DJ.